Hello, let's learn about respiratory central nervous system and gastrointestinal tract infections. Start with respiratory infections. Let's just understand the clinical presentation of upper respiratory infections. Upper respiratory infection manifests as either rhinitis, sinusitis, ear infection, or acute pharyngitis. They are mostly viral. 45% of this upper RTI are 45% are viral. Uh, if it is acute pharyngitis, it is mostly caused by group A streptococcus or other bacteria. So upper respiratory infections are mostly viral. Routine testing is not required. They are self-limiting illness with symptomatic management. When to suspect bacterial sinusitis or otitis media, persistence of any of the following such as persistent symptoms or signs lasting for more than 10 days, high fever and purulent nasal discharge or facial pain lasting for at least 3 to 4 consecutive days at the beginning of illness. Then double sickening, worsening symptoms or signs characterized by a new onset of fever, headache or increase in the nasal discharge after 5 to 6 days of a typical viral infection which is initially improving. Routine lab assessment is not required. Clinical management suffices unless intractable, recurrent, or chronic rhinosinusitis. Then, when to suspect fungal sinusitis, symptoms when symptoms worsen or fail to improve after initial antibiotic therapy, or even after broadening the coverage or switching to other different antibiotic class. Then, second is severely rapid progressive disease in immunocompromised diabetic patients with acid disease, transplant recipients, patients with hemorrhagic malignancies, or chronic glucocorticoid or deferritin therapy. The mucormycosis we suspect when there is black necrotic eschars of the nasal cavity and turbinates and facial lesions and exophytic or necrotic lesions of the hard palate. Let us understand the clinical clues of bacterial and viral pharyngitis. Bacterial, there is sudden onset of symptoms, sore throat and odonophagia, fever, headache, nausea, vomiting, abdominal pain, inflammation of the pharynx and tonsils. Then there is patchy or discrete exudates, tender and large anterior cervical lymph nodes, ages about 5 to 15 years, occurrence mostly in cold weather. Then there's history of exposure to streptococcal infection. While viral, it causes conjunctivitis, coryza, cough, diarrhea, and discrete ulcerative lesions. Let us understand the modified center score, also called a severity score for bacterial pharyngitis. The parameters in this central criteria include temperature more than 38 degrees Celsius, swollen tender anterior cervical lymph nodes, then tonsillar swelling or exudate, then the age, either 3 to 14 years or 15 to 44 years or more than 45 years. Accordingly, either +1 or 0 or -1 is allotted. Then based on the center scores, if it is less than, if the score is less than 0, the risk of streptococcal infection is about 1 to 2.5%. If it is 1, the risk of strep infection is 5 to 10%. In such case, with a score of 0 to 1, no testing or antibiotics is required. But if the score is about 2 and 3, gas ICT, if positive, treat, if negative, and clinical suspicion, high sense cultures. If it is more than 4, treat empirically, even with or without cultures. So based on the center scores, we have the risk of streptococcal infections and the line of management. How to manage the epiglottis case? Immediately admit the patient to the nearest hospital. Avoid instrumentation. Insertion of tongue depressors or other instruments may provoke airway spasm and precipitate respiratory compromise. Monitor for the respiratory fatigue visually and with continuous pulse oximetry. Administer oxygen according to pulse oximetry results. Have equipment and personnel available for immediate intubation. Start IV antibiotics after collecting culture specimens. Empirical coverage for H influenza is appropriate. Common choices include ceftriaxone, orthogenesis, cephalosporin, cefuroxime, and cefamendel. Correct volume deficits with IV fluids avoid sedatives. How to manage laryngotracheitis? Hospitalization may be necessary, especially in infants and young children who have hypoxemia, volume depletion, and areas of airway compromise or respiratory fatigue. Mild cases of croup, that is laryngotracheobronchitis, may be managed at home with moist air inhalation. Hospital patients require monitoring for respiratory fatigue, visually and with continuous pulse oximetry. Expertise for immediate intubation and access to the necessary equipment are required if respiratory failure is a possibility. Administer humidified oxygen to all hypoxemic patients. In patients who do not require oxygen therapy, a cool mist humidifier may be used. IV or oral glucocorticoids are commonly used to reduce symptoms and shorten hospitalization in patients with moderate to severe croup. Inhaled racemic epinephrine may be temporarily dilate the areas. How to manage rhinosinusitis? Most cases of acute rhinosinusitis include mild and moderate bacterial sinusitis. Resolved without antibiotics. Consider antibiotic treatment if symptoms persist without improving for 10 or more days, or if symptoms are severe during a period of 3 or 4 days or longer. Give first line antibiotics for 5 to 7 days in most adults, for 10 to 14 days in children. Begin treatment with an agent that most narrowly covers like pathogens like Streptococcus pneumoniae, non-tapeable H. influenzae, and Maracella catarrhalis. Initial first-line options include coamoxiclo. Alternatives in penicillin allergic patients are doxycycline and respiratory fluoroquinolones. In patients who worsen or do not improve after 3 to 5 days of empirical therapy, consider resistant pathogens, structural abnormality, or non-infectious etiology. Adjunct therapy for adults include nasal saline irrigation and intranasal steroids. How to manage group A streptococcal disease? Oral penicillin or amoxicillin for 10 days for patients with an allergy to penicillin. If compliance is a concern, consider single IM injection of benzoyl penicillin G. A first generation cephalosporin may be used in patients with non-anaphylactic penicillin allergy. Options of penicillin allergy in patients include clindamycin or clarithromycin for 10 days or azithromycin for 5 days. Let's see about the readily available POC tests, point of care test for upper RTI. One is COVID-19 screening by antigen testing. If negative but patient is symptomatic, send RT-PCR. Another is for influenza PCR, rapid immunochromatographic test. Testing is recommended only in outbreak situations. For group A streptococcus, testing is recommended based on Centaur score. Rapid CAT test is available. Culture if CAT test is negative. What are the specimen collections? Nasopharyngeal swabs are not recommended for otitis media or sinusitis. Send an aspirate for culture. Use a Dacron swabs for viral culture or calcium arginate flogged swabs for collection, and not cotton. Cut exudate from behind the vulva and swab. Both tonsillar pulses, the posterior pharynx, any cut secretions or area of inflammation. Clinical, what is the clinical present? Lower respiratory tract infection, cough, fever, and other symptoms more than 3 week duration. Tuberculosis. A cough without expectation, shortness of breath, periodic chest pain with high fever, chills, chest pain, or rapid breathing less than 3 week duration, then health-associated pneumonia or community acute pneumonia. What are the causes of community acute pneumonia? Bacterial causes include Streptococcus pneumoniae, Klebsiella pneumoniae, H. influenza, Staph aureus, group A Streptococcus, Burkholderia pneumoniae. For viral causes include influenza, SARS-CoV-2, parainfluenza, respiratory syncytial virus, adenovirus, rhinovirus, and human metapneumovirus. The article pathogen causes include chlamydia, pneumonia, Legionella pneumophila, mycoplasma pneumonia. It is important to note that mycobacterium tuberculosis is an important pathogen which can present as community-acquired pneumonia in TB endemic areas like India. The common mistake doctors diagnose pneumonia on the basis of hearing crackles on auscultation of the chest. This is a mistake. Crackles in the chest generally indicate heart failure or fibrosis, but not pneumonia, especially in the elderly. What is the pneumonia severity score? We have various scores like CURB 65, CRB 65, SMART COP, or SMRT COP, or ATS IDS criteria. You can refer to the article Gupta D. et al. Lung India published in 2012 for the same. What is this pneumonia severity score? CURB 65 score and ATS IDS criteria tells us about. CURB 65 score stands for confusion, uremia, respiratory rate, blood pressure, and age. In age more than 65 years, blood pressure less than 90 systolic or less than 60 diastolic. Respiratory rate more than 30 per minute. Uremia, that is blood urine nitrogen, more than 19 mg per deciliter. The overall CURB 65 score ranges between 0 and 5. 0 is for no risk pneumonia, 5 is for very severe pneumonia. In the case of cumulative scores of 0 or 1, ambulatory treatment is required. Score more than 1 require hospitalization. Score less than 1 require hospitalization. If ATS IDS criteria, the major criteria is septic shock with need for vasopressors, respiratory failure requiring ventilation. Then the minor criteria is respiratory rate more than 30, PaO2 to fast range capacity of oxygen ratio is less than 250, multi-lobar infiltrates, then confusion, uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension. So the severe pneumonia in this criteria refers to either one major criteria or 3 or more minor criteria. Again, you can refer to the 2007 in IDS criteria for this CURB 65 ATS IDS score. CURB 65 can often be discharged on oral antibiotics. CURB 65 score of 2 usually require observation in hospital. CURB 65 score of 3 to 5 usually require admission to hospital. What are the causes common? Staph aureus, Streptococcus pneumoniae, H. influenza, mycopathy pneumonia, Legionella pneumonia, chlamydia pneumonia, and viral causes include influenza virus, parainfluenza virus, respiratory syncytial virus. If history of COPD, then in addition to this, we have Pseudomonas aeruginosa. And if there is aspiration, again to addition to upper organisms, we have bacteroides and Fusobacterium. If it is zoonotic, then the cause is Chlamydia psittaci. And if it is empyema, the cause is Staph aureus, Streptococcus pneumonia, Streptococcus anginos. What is a warning? Two conditions which are often missed and are not covered by the normal antibiotics used to treat common acquired pneumonia are tuberculosis and pneumocystis carinii pneumonia. Tuberculosis is considered in patients from endemic countries returning or traveling or contacts of people with tuberculosis, while PCP considered in patients with HIV infection or those who are risk factors of HIV infections. What is the myth? Doctors traditionally refer to atypical pneumonia. However, this is a poor term. Atypical pneumonia is a pneumonia caused by bacteria that cannot easily be grown in a microbiology laboratory. Microbiology pneumonia and chlamydia pneumonia are the causes. It was a Victorians' first coined phrase as they could not identify this bacteria. However, with modern methods, atypical pneumonia were identified and found to be common causes of pneumonia. Hence, the atypical is a misnomer. Clinically, there is no difference between how different bacterial pneumonia present. The condition could be called microbiology pneumonia or chlamydia pneumonia, but not atypical pneumonia. Just like we have the term staphylococcal pneumonia or streptococcal pneumonia. Atypical as a term should really be abolished, and non-culturable, for example, should be used. What are the investigations? No testing is recommended uh, for in OPD settings or non-serious admitted patients, except X-ray and routine evaluations. Chest X-ray for all patients. Chest X-ray is not recommended as a follow-up test. Routine tests include CBC, TLC, DLC, kidney function test. Sputum gram chain is adequate for severe CAP, patients being empirically treated, patients previously infected, and patients who were hospitalized in the last 3 months. For Legionella pneumococcus, we have urinary antigen for severe cough and association with Legionella outbreak. In influenza testing, we have nucleic acid amplification test, and then serum procalcitonin level is another test. Only should be used only for de-escalation or for stop. For nocardia, tuberculosis, or fungal pathogens, we have molecular acid test like and NAT. Then for opportunistic pathogens, should be suspected in immunocompromised patients. How to manage CAP? Based on the conditions, so based on the likely causative pathogens, have the empirical therapy for mild to moderate cases and severe cases as shown in this chart. Have alternative antibiotics in your antibiotic policy, and with comments. Sputum is the most common criteria specimen. Sputum is acceptable only for microscopy and culture based on Bartlett's criteria. Identify the special process the sputum or observe the sputum for microscopy and proceed. Endotracheal aspirate is should be collected on patients who are ventilated and those who cannot export the sputum. And other samples include bowel fluid, mini bowel, lung tissue, and bronchial process. So this is about Bartlett's criteria too. We have seen in our one of the session about Bartlett's criteria. Here also we will try to speak in short. Bartlett's criteria is significant when the pus cells are more than 25 per low power field and epithelial cells less than 9 per low power field. How to transport the respiratory cultures? Place it in a transport media, force medium, amines transport medium, or at an ambient temperature in a sterile container. Refrigerate only if there is a delay of more than 1 hour anticipated. If suspected Neisseria, then it should be directly inoculated into culture media, pre-warmed chocolate agar plates. That's all from this session. We'll see in detail about the other infections like gastrointestinal and CNS infections in the next session. Thank you.